All right. Thanks, everybody. I'm Ben Andrews. I'm a internal medicine doc at Christ Community Health Services in Memphis. Most recently, I was in Zambia for 4.5 years with Vanderbilt University and University of Zambia, which is where I've probably seen most of my cryptococcal meningitis, which is going to be the subject of our talk today. We'll start with a brief case. This is sort of an amalgam of cases, not necessarily a specific patient, but a 23-year-old female with HIV presents with 3 weeks of worsening headache, intermittent diplopia. Patient stopped taking her ART about 9 months ago, was never really taking it very well to begin with, but was brought in today because she may have had a little bit of confused speech or didn't seem quite right by her family members. Last CD4 count on record was 39 with a viral load of 189,000. On exam, she seems pretty with it, although her level of consciousness might be a little bit decreased. Fundoscopic exam shows some papilledema. CT scan shows no mass lesions, and lumbar puncture is done. Lumbar puncture shows an opening pressure of 25 centimeters of water. The white blood cells were 19 cells per cubic millimeter, and they did an India ink stain, which is shown here. Since we already know the title of the talk, this is cryptococcal meningitis. You see the India ink, you see the encapsulated organisms, which you also see in the background of all these slides. So today, this is a pretty classic sort of presentation for cryptomeningitis, although it certainly has a spectrum of presentation. Feel free to stop me at any time. But this is a little bit of the epidemiology. It's a spherical budding yeast. Crypto was first described as a human pathogen over 100 years ago. Cryptomeningitis was first described in the early 1900s, so long before we had known HIV/AIDS. There's an estimated 950,000 cases worldwide each year, with an estimated 600,000 crypto-related deaths. And the mortality due to crypto varies widely from depending on the setting. So the estimate in high-income countries is probably 9% case fatality to as high as 70% in sub-Saharan Africa, and a lot of that being related to how late people are when they present for care. Obviously, with a lot of conditions, the later you present, the higher the mortality, and certainly the higher the morbidity as well. So there are 4 serotypes of Cryptococcus. There's C. neoformans grubii, there's C. gatti, and then there's C. neoformans. Pretty much all 3 of them can cause, or all 4 of the serotypes, all 3 sort of types can cause a cryptomeningitis type of picture. What we frequently see, particularly here in the Southeast, is C. neoformans. I know certainly in Georgia, where the soil is just teeming with Cryptococcus, that's what we get a lot of. We do see gatti occasionally here in the Southeast, although probably those were patients who were infected elsewhere in the Pacific Northwest, sort of drier, more moderate climates, and I guess it's associated with eucalyptus as being where it tends to grow. Neoformans, and Neoformans grubii are also really associated with pigeon droppings. So this is just sort of a brief pictorial on the pathophys of Cryptococcus. It's really an environmental exposure. Farmers, you kick up a little bit of dust, those spores get kicked up and you inhale them. Once you inhale it, it gets into the lungs, gets lodged in the alveoli, it kind of just hangs out there. It can cause significant pulmonary disease, even in immunocompetent patients, can cause pulmonary disease, which can range widely from just a minor self-limited respiratory condition to obviously the more suppressed you are, the more serious it can be, and then it can disseminate. But more commonly, this is a disease of reactivation. So the patient may have gotten a little tiny, cough or something that resolved after a few weeks, never really noticed anything about it. And then years later, when the CD4 count went down, the organism disseminates and goes to the central nervous system. Just a little bit sort of the clinical history you would expect from a patient with cryptomeningitis. And again, this is very, think about the case, a lot of these were present, but it tends to be a subacute onset, days to weeks, maybe a month, not super chronic, because after a few weeks, usually the symptoms get significant enough that the patient's going to seek medical care. The symptoms can be severe or progressive headache, sometimes starts relatively mildly and gets worse. There's a fever, typically in about half of patients when they're presenting. They can get some nausea and vomiting, photophobia and blurred vision, mental status changes, seizures. Typically, all of these symptoms are related to increases in intracranial pressure. So initially, it doesn't cause a whole lot of inflammation of the meninges, but as it starts to raise the intracranial pressure, you get all of these symptoms due to raised ICP. And the more progressive it gets, the more progressive the raised ICP gets, the more you might get compression of cranial nerves and things like that. Physical exam in cryptomeningitis. Like we mentioned, the vitals, they're often febrile about half the time. On neurologic exam, you can get meningismus, although it tends to not be present in the majority of patients, so present about a third of patients. You do get signs of intracranial pressure elevation, including papilledema, which we mentioned on fundoscopic exam. Visual disturbances, again, this can be due to compression of third nerve as you start to get some pushing down on the cerebral tonsils and things like that. Visual, oops, sorry about that, that's my wife. Visual disturbances, focal defects. You can get a molluscum-like rash. The rash actually can present a variety of different ways, but these are a couple variations. One is that umbilicated, hyperpigmented rash you see on the left, which is can very frequently be mistaken for molluscum. And then on the right there, you see that they're kind of crusting a little bit and becoming a little more irritable. And even that looks could potentially be mistaken for like a basal cell carcinoma when they get very big, but with multiple lesions throughout. As far as diagnostics, of course, you're checking your CD4 count. Usually the CD4 count is less than 100. Certainly you can see it slightly higher. You can see CD4s up to 200. Rarely you can see them over 200. But by and large, it is truly an opportunistic infection. And once you're below CD4 of 100, the risk goes up considerably. Lumbar puncture. So the pressure is often high. Really, the higher the pressure, the more likely it is that it's cryptomeningitis. That helps to distinguish it to some extent from other types of meningitis. You can show cells, but you may not. So the India ink India ink is usually around 75% sensitive. So a quarter of patients with cryptomeningitis may have a negative India ink. You can get a little bit of protein elevation, although when you see much higher protein levels in the CSF, you're thinking more about bacterial meningitis, tuberculous meningitis, even neurosyphilis, and probably less likely to be cryptomeningitis. You do see a low glucose, which puts it in the range with bacterial meningitis. And then we mentioned the positive India ink or the CSF cryptococcal antigen. You can also do a serum cryptococcal antigen for patients who refuse lumbar puncture, for example. And serum cryptococcal antigen is pretty good. Both the serum and the CSF cryptoantigen in an appropriate patient with the appropriate clinical findings are better than 95% sensitive and specific. If you're talking about a patient without symptoms and you're just doing you happen to check a serum cryptoantigen for some other reason, the specificity for cryptomeningitis goes down because you can get antigenemia without meningitis. But if the patient comes in with a clinically characteristic picture and the serum CRAG is positive, then it's cryptomeningitis pretty much. This is one of those tests that you can pretty much trust pretty well as being accurate. So some prognostic signs for cryptomeningitis. If a patient comes in with altered consciousness, it's not a good sign. Usually, no matter what their condition is, altered consciousness is not a good sign, but certainly with cryptomeningitis, that's the case. All of these portend a increased risk of mortality. As far as CSF characteristics, very, very high cryptoantigen titers or very, very high quantitative culture colony counts indicate more significant fungal burden. Elevated CSF opening pressure. The higher the opening pressure, the higher the risk of mortality. If you have low CSF white count, suggests that the patient is particularly immunosuppressed and is not mounting any kind of response to the fungus within CNS. Of course, low CD4 counts and low serum albumin has also been associated with increased mortality, just as a marker of patients with significant chronic condition. Just a little more about CNS involvement of the organism. So nearly half of CT scans in Cryptococcus will be totally normal. So the organism gets into, so it's spread hematogenously, gets crosses the blood-brain barrier, gets into the meningeal area especially. Doesn't, as we mentioned earlier, doesn't cause a lot of meningeal inflammation, but it essentially just causes this munking up or gunking up of the meningeal spaces, and so it spreads along these perivascular Virchow-Robin spaces, which is you see as the blood vessels get deep into the parenchyma. But it essentially, as organisms lyse, their cell walls start to clog up the reuptake of CSF. So the CSF, which is continually produced and continuously returns into the bloodstream, it gets blocked off, and so the production continues, but the resorption does not, and you end up just building up more and more and more CSF in the inside the brain, so that you get the ventriculomegaly and hydrocephalus. Untreated, it can develop into parenchymal involvement. So as it penetrates down into those Virchow-Robin spaces deeper, you get pseudocysts, and then you can develop cryptococcomas, which you see in the sagittal MRI there. We mentioned hydrocephalus, so there's just an image of hydrocephalus, and as you get the hydrocephalus, you start to get the papilledema, which is also shown here. As far as treatment, this is just from both the 2010 IDSA guidelines, and then also the 2013, I believe, was the last update revision on the DHHS opportunistic infection guidelines for as far as the crypto section. Preferred method of induction is liposomal amphotericin B plus flucytosine. Alternatives would include ampho-B lipid complex or ampho-B deoxycholate, also with flucytosine. Other regimens that you can use would be liposomal amphotericin by itself, or there's ampho plus fluconazole, which, depending on the study you look at, may or may not show any improvement compared to ampho. But really, ampho plus flucytosine tends to be the best combination. The reason liposomal ampho is preferred over the lipid complex and deoxycholate is mainly one of side effects. So you can get higher concentration with fewer side effects using the liposomal formulation compared to the deoxycholate. And we'll talk just a second about the side effects. of AMPHO. But consolidation therapy. So usually we treat for 2 weeks with induction therapy. After 2 weeks, or right near the end of the 2 weeks, you usually want to try to assess whether the patient seems to have responded well to therapy, usually with a culture at 2 weeks. If they seem to have responded well to therapy, the follow-up culture is negative. We do consolidation with sort of moderate dose fluconazole, 400 milligrams daily for 8 weeks. And then after the consolidation, we put them essentially on lifelong fluconazole 200, or until the CD4 count is over 100 for at least 6 months with an undetectable viral load. As far as DHHS guidelines, I think crypto is the only one with secondary prophylaxis that also requires the undetectable viral load. With PCP and Toxo, usually it's basically just a CD4 criteria for stoppage, but they actually include a viral load criterion as well for crypto. So AMPHO-B toxicity, this is a renal tubular toxicity. You can get increased creatinine, and reduced renal function, hypokalemia, hypomagnesemia. One series in Zambia, they showed that, well, a significant number of patients came in hypomagnesemic anyways because they weren't eating well for their 5 to 6 weeks of crypto. But then after starting AMPHO treatment and during their hospitalization, within a week, all of them actually were hypomagnesemic. AMPHO-B itself causes fevers, rigors, chills, particularly if it's infused quickly, particularly with the older deoxycholate. The liposomal has fewer, but you still can see it. In addition to treatment with pharmacologic treatment, really management of elevated ICP is huge. So on the initial LPs, you see that in the picture that the provider there is checking the opening pressure. And really, crypto is the most important infection where opening pressure is key. So typically you want to check it, and if the opening pressure is elevated, you want to reduce the pressure by 50%, usually taking off as much as 20 to 30 milliliters of fluid, or at least get the pressure below 20 centimeters of water. Repeat LPs are frequently needed to control the ICP. The higher the ICP was to begin with, the more frequently you're going to want to recheck. Because let's say you have a patient with an opening pressure of 40, you get them down, let's say, to 20 or 18. If you tap them again the next day, they might be back up at 25 or 30. And you bring them back down 50%, tap them the next day, they might still be at 25 or 30. And so sometimes it's daily until the ICP is not going up. The opening pressures, as they come down each day, you start to say, okay, now I feel comfortable. We don't have to keep repeating this every day. It's actually great for medical students to have a crypto meningitis case because they get a lot of practice with their lumbar punctures. And you can also follow symptomatically to some extent. Frequently, these lumbar punctures are really therapeutic. A patient with an opening pressure of 50 is going to have significant symptoms from their raised ICP. If you take off 20 or 30 cc's of fluid, bring that down to 25, their headache will frequently improve significantly. Their visual field changes and their diplopia will improve, and so they'll actually frequently be very willing to have repeat lumbar punctures. Steroids are not beneficial and may be harmful and further weaken the immune system. So in typical cases of crypto, you don't want to use steroids, although if you have a case of iris, it's sometimes necessary to control the immune reconstitution. As far as monitoring treatment response, ICP management is described, as I mentioned earlier. You want to repeat the lumbar puncture and CSF culture at or just before day 14. I think we used to do it around day 11, day 12, so that you've given it at least 48 hours by day 14 when you're deciding when to send the patient home from the hospital. You say, okay, that culture is 48 hours negative. I'm comfortable with stopping the AMPHO and moving on to fluke. You don't use a cryptoantigen to monitor treatment, partly because it detects dead antigen as well. or dead organisms. And so really the culture after treatment is the key for monitoring response. The timing of antiretroviral therapy. This is still an issue that's a little bit in flux as far as what is the optimal timing. There are about 3 or 4 studies that are useful in sort of guiding this, but I'll focus on the 2 sort of landmark studies. One is the Zlopa study, which was from 2009. And this was a study done mainly in the United States. I think there may have been an Ireland site as well, but this was a US study. Patients with a whole range of opportunistic infections who are in the hospital and starting ART less than 14 days after diagnosis versus 6 to 12 weeks after diagnosis as an outpatient. And so in this study, 63% of patients had PCP, only 35 patients, or 12% of the overall population, had cryptomeningitis. So it was a very small sampling for the cryptomeningitis. What they found overall was that there was a lower incidence of death or AIDS progression, like new AIDS defining conditions in the patients who were started early. And most of I think the median start time for patients, I think I used to know this, but I think it was around 12 days, with ranging from 9 to 14, I think, in the early ART group. So it wasn't super duper early. It wasn't the first week, for example. So what they found, especially in patients with C4s less than 50, as you expect, getting them on ART earlier will reduce their likelihood of another AIDS-defining illness. But again, the crypto patients, there are only 35 of them. It's too few to have any kind of statistical significance, although the trend really showed probably the same benefit in them as it did in the patients with PCP. Now, this is a more recent study published last year that was done in Uganda and South Africa. They compared starting ART in the 2nd week of treatment, so between day 7 and 13, versus 5 weeks after diagnosis, so after completing the induction and even sometime into the consolidation phase. And patients were treated with Ampho plus fluconazole. They did get multiple lumbar punctures. So one of the criticisms of this was in Africa that we certainly do not do daily lumbar punctures as aggressively as in the United States. But in this study, the median number of lumbar punctures was 3. So they did at least have 2 follow-up LPs, and some had more as needed. What they found, 26 weeks, there was a 45% mortality in the early start group versus a 30% mortality in the delayed start group. When they looked at what were the markers for this, they found that early ART was particularly harmful in patients with altered level of consciousness, high fungal culture burden, because they were doing culture colony counts, as well as if they had a CSF white blood cell count of less than 5. And this study was actually stopped early due to harm in the early ART group. And so this study, a lot of people in the U.S. sort of discount this study and say, well, you know, that was Africa and we're the United States, and it's a different picture. And it is a different picture. But certainly we have lessons to learn from that. And so, sorry, before we go on, this is just to show you that those with the CSF white cell count less than 5, you see the curve separated very quickly and remained separated for pretty long follow-up 1 year out. Whereas those with the CSF white count greater than or equal to 5, the curves were almost identical. And so as far as the timing of ART initiation, DHHS doesn't really give explicit guidelines on this. They just sort of gave rough summaries of the available evidence at the time, and left it a little bit open to interpretation. So my interpretation, if the CSF white count is less than 5, I would wait for 4 to 5 weeks regardless. I would not start those patients on ART up front just because of the risk of iris and the risk of causing significant increasing the ICP even further. If the CSF is greater than 5 white cells and the peripheral CD4 count is less than 50, then those patients are at increased risk of developing new AIDS-defining illnesses if you wait to start ART. And so I would consider starting after 2 weeks, particularly if the opening pressures on the CSF were low or had gotten low. Early ART is probably safer, but I would generally not start before 2 weeks. And most patients, I would wait 4 to 5 weeks. If the patient was on ART at the time of diagnosis, then you continue ART and you manage the ICP like we talked about. If you think that they're developing iris, steroids are an option at that point to help manage the iris, particularly if on a subsequent lumbar puncture they were to have just a lot more white blood cells, for example. It would be for iris.